Basically, you have the musculature of the shoulder, the supraspinatus, infraspinatus, and subscapularis teres minor. These make up the rotator cuff, and it's surrounded by the acromion, which is a bony shelf, and the ball is underneath the muscles. Next slide. What are some of the symptoms that you may have of a rotator cuff tear? This is also true for impingement syndromes, which I'll talk about in a little bit. Pain at rest, pain at night, particularly when you're sleeping on the affected shoulder. The pain is mainly over the apex of the shoulder. Rarely will it radiate past the elbow. If it's going past the elbow, it's usually neck-related. Pain when lifting your arm up, it's usually from about 35 degrees up to about this level. You notice lifting pain. It doesn't have to be very heavy. It's just when you get your arm in a certain position, it's painful. You may notice some what we call crepitus, which is some grinding or crackling or rubbing, kind of like leather rubbing over leather when you move your shoulder. You may also notice some limitations of motion in your shoulder. Now, for women, I asked them, can they undo their bra and back? They can't reach back anymore. For men, they can't get into their wallet, and that's when they come in. This didn't show up that well, but this is an arthroscopic view of a rotator cuff tear. This should be coming down and attaching right here to the bone. Why do we get rotator cuff tears? Well, the rotator cuff doesn't have a good blood supply. This is all white tissue here that you see. That means there's not good blood going through it. And if there's not a lot of blood going through it, it doesn't heal well, and it will tear. Repetitive stress. Usually we see this after the first snowstorm. Everybody's out shoveling snow. And then a few weeks later, they come in, they say, you know, I hurt my shoulder shoveling snow. I don't remember doing any one specific thing, but I can't lift my arm now. They can have bone spurs off their acromion that I'll show you later. And this can cause an impingement syndrome where if you have a bone spur here and you just imagine lifting your arm out to the side, you're hitting that spur. So we flatten it out and give you more room to go. And this is a diagram of an impingement syndrome with the arm down. You can see there's plenty of room between the rotator cuff and this acromion bone. When you lift the arm out to the side, the rotator cuff gets pinched between these two, and that gives you a tendonitis, bursitis, partial tears, or full tears if it's allowed to continue for enough time. Shoulder impingement is an early stage of a cuff tear, and if you allow it to continue, you can end up with a tear. So we try and be more aggressive in treating the impingement so that you don't progress to a cuff tear. Next, please. Rotator cuff tear can occur after a fall. Here you see the tendon should attach to the bone. And the mechanism of this is that the rotator cuff pulls your arm out to the side. That's simplifying it. It actually pushes your arm down, but it helps pull your arm out to the side. If you fall on your arm, it's going to push your arm down and separate it. The rotator cuff is trying to keep it out here so it braces the fall and it doesn't hurt as much. And when your arm gets forced down, the tendon gives and you get a tear. And that would be a longitudinal or a horizontal tear. Next. These can also occur over a period of time, months to years. It's from repeated microtrauma or repeated inflammation in the shoulder from a chronic tendonitis or bursitis. Again, it's because of a poor blood supply and impingement. If I get in your way, just tell me. Next one, please. This shows a partial thickness tear. And if you were to look at a rotator cuff in a cross section, it's a thick tendon. And you can get a partial tear where a few fibers tear, or a more significant tear where half of it tears, to where there's only a few fibers left, to a complete tear. And treatment depends on what kind of tear you have. This is what a full thickness tear is. There's a hole in the tendon, and you can look right through and see the bone. Next, please. And this is just an arthroscopic view of a rotator cuff tear. This is the rotator cuff coming over top, and it's lifted off the bone. This should be attached down here, and I'll show you some other pictures of that and how we repair it. Everybody wants to get an MRI of their shoulder to see if they've got a tear. This is what an MRI of a tear looks like. This is the ball, the socket, and this is the rotator cuff coming across, and it should attach to right here, and here you see a defect. And the best way mechanically to think of a rotator cuff tear and what it does is, if you've got a car, you've got a motor, which is the muscle. You've got a wheel that turns, but the rotator cuff is a transmission, so there's no power getting to the arm, and that's why they can't lift their arm out to the side. Partial tears we treat by rest, activity modification. We try and avoid anything above shoulder level. Keep all your work down in here. Strengthening exercises and physical therapy, and Gary will talk about that. The rotator cuff actually keeps your shoulder down when you lift it out to the side. That's the main function of it. So we strengthen those muscles. Steroid injections. Now, you get a steroid injection. I tell patients to take the pain away so you can do your physical therapy. The physical therapy is what's going to cure this problem, not the pain medicine. The injection is not a license to go out and play tennis, shovel snow, and do all this other stuff. It's to decrease the pain so you can sleep and you can heal the arm. If there's a larger tear requiring more than 50%, it usually requires surgery because it's not going to heal, and that's because of the poor blood supply. When we talk about surgery, if you've had symptoms for 6 to 12 months with a small tear, a large tear more than 3 centimeters, we know it's not going to heal, so that's going to need surgery. If there's significant weakness and loss of function of the shoulder where you can't lift it up more than that level, or if it's an acute tear that was caused by a recent injury. You know, you fell on your arm, you can't lift it. We know they're going to do far better if they're repaired acutely. Leaving these go a long period of time, the tendon retracts, the muscle fibroses, and it's much more difficult to get the tear back to where it belongs, and it does not heal as well. And some of them actually cannot be repaired. So there's several different ways to perform a rotator cuff repair. There's the arthroscopic technique, a mini open technique where we just use a real small incision, or the old excuse me, open repair where there's a large incision. And if there's a very, very large tear that can't be repaired, we do what's called a reverse total shoulder replacement. It's a special kind of shoulder developed for massive rotator cuff tears and arthritis that cannot be repaired. This is what a schematic of a rotator cuff repair. This is the rotator cuff. There's a little like molly bolt with sutures coming out of it, and we use that to tie the rotator cuff back down to the bone. And I'll show you a recent surgery that I did with that. Open cuff repair is kind of gruesome. This is the head up here, that's the armpit, and the collarbone, and it's a pretty big incision in the arm. Next. Later on, there's the mini open cuff repair. It's a real small incision, maybe an inch, just enough to get some instruments in there, get some sutures in the rotator cuff, and tack it down. Nowadays, we almost all use suture anchors because this tissue is avascular and you're reattaching it to bone, and you can't put sutures into bone. They're not they're not going to heal. It's like trying to put it into wood. So we use like a molly bolt type of affair to do it. Arthroscopic repairs are small incisions. We have to use special instruments to do it, a special shaver, special tacks, special suture passers, a video camera, and the healing is much faster because we're not making these big incisions. Next. This is what a normal rotator cuff looks like through the arthroscope. That's the bone, and the rotator cuff is coming down and attaching. This is what a tear looks arthroscopically. Here you can see that the tissue now pulled off the bone. It doesn't show as well here, but this is a white tissue. When you look at it live, you'll see it's white. There's very little blood supply going there. And again, this is what it would look like with sutures coming in to tack it down to the bone. Next. Another diagrammatic of a tear being repaired. Next. And that's what the completed repair looks like. Next. Can we turn down the lights just a little bit so this shows better? This is a video of an arthroscopic repair. Here I am probing the hole. That probe is going in to the hole in the bone, in the rotator cuff. And notice how you don't see any bleeding here. It's all avascular tissue. Okay, this is the probe coming in. And I'm just trying to see how big the tear is and how mobile it is. You're going to see a special instrument come in. This is a suture passer, and this is like a clamp. I'm going to grab the tissue, open the jaws. You're going to see the sutures come out. That's deploying the suture. And now that's suture in the rotator cuff and coming through. We're going to feed the suture through. And now there's a good braided suture. That's about 1.5 millimeters thick in the tendon. Now we're going to come down here. I'm going to make a hole to put the screw in. Here we come. This is the instrument coming in to make a hole. And we actually have to tap the bone. You'll see the screws coming in, the threads coming in. I'm tapping that part in, but you see these are threads. These are cutting the threads for the suture anchor. It's a tap. Next, I'm going to pass the suture, the actual anchor in there, the molly bolt in. That's a white bioabsorbable material, and that's got the sutures held in it. I'm going to screw it into place. And then start ratcheting it down and tightening the sutures. You'll see the sutures come down. You see them coming into the anchor. And that's pulling the torn portion, that hole, closed. The anchor instrument comes out, and we're going to cut it. Now, just for perspective, that molly bolt, that suture that I put in there, is 5.5 millimeters thick. So there's a lot of magnification with the TV camera. And that's just cutting the suture. And that's a completed repair. Okay, next. If we can't repair it and you develop an arthritis in the shoulder, we do what's called a reverse shoulder replacement. And in this case, the ball is at the end of the socket, and the socket's at where the ball normally is. The reason that we do this is in a normal shoulder, if this big muscle contracts, it would pull the shoulder up. But what the rotator cuff does is push the shoulder down. If you don't have any rotator cuff in here, when this muscle contracts to pull your arm up, this is more horizontal and holds it down. But there's not a big indication for this. It's only for more severe tears, elderly patients, and secondary arthritis in the shoulder. Next slide. This is a conventional total shoulder where the ball is just cut off, a stem and an artificial ball is placed, and sometimes we'll replace the socket depending on how bad the arthritis is. This is used for osteoarthritis or arthritis of wear and tear, rheumatoid arthritis, post-traumatic or after fractures. Sometimes we have to do this when the ball can't be repaired. If you have a combination of a severe rotator cuff tear that's not repairable and arthritis, we do a shoulder replacement. People who are on steroids for asthma, pulmonary, GI complaints can develop a condition called avascular necrosis where the bone actually dies, and that leads to a severe arthritis in the shoulder. And we can also do it for failed previous surgery. Next. About 23,000 shoulder replacements are done a year, and this compares to about 700,000 hip and knee replacements done a year. So it's not as common a procedure, but it's still a fair number that are done yearly. Next. When you're talking about arthritis in the shoulder, you're talking about bony pathology versus the rotator cuff, which is soft tissue. And what you see in x-ray findings are loss of this space between the head of the humerus or the ball and the glenoid or the cup of the shoulder. You can see flattening of the head. You can see bone spurs in here or under the ball, or loose pieces of bone floating within the joint, and those would all be signs of arthritis in the shoulder. This just shows the difference in the two shoulders, two types of shoulders. This is a traditional shoulder replacement, and this is a reverse shoulder. Here you can see the ball is attached to the end of the humerus, and the socket is in the socket of the glenoid. Here you see the ball on the end of the glenoid and the socket here. But if you can just imagine this muscle pulling up over here, it would just pull the arm right up. There's nothing to hold the ball down, versus this is underneath that ball, and that keeps it in place and allows the arm to rotate laterally. Next. Symptoms of arthritis are pain, loss of motion, that grinding sensation, lack of sleep, stiffness. You've all heard of these. Next. What are the non-operative treatments for shoulder arthritis? Well, number one, you got to rest it. Moist heat can ease the pain. If you've been exercising it a lot, ice helps, particularly at night. Physical therapy is a mainstay of arthritis. In our group, we're very aggressive in physical therapy. Non-steroidal medication used to be the mainstay of treatment. I don't know if you remember, Vioxx was a great arthritis drug. It was taken off the market because they found that there was a much higher incidence of heart attacks and heart events after Vioxx, so they took it off the market. Well, then they went back and looked at all the old drugs, the Motrin, Advil, and all those, and found that they all have the same effects but to a lesser degree. So when you're taking over-the-counter Advil, you're still increasing your chance of a heart attack, GI bleed, and kidney disease, and liver with some of them. So we're much more careful in recommending the non-steroidal medications than we used to be. Periodic cortisone injections can help with the pain. The problem with cortisone injections is that they interfere with cartilage metabolism, and over a period of time they can make your arthritis worse. Next. Again, this is the conventional shoulder replacement. It's a metal ball with a socket. It's patients who, at the end of it, if you were to open up a joint and look inside, you'd see the ball, like in a chicken joint, it's covered with a nice white pearly substance that's slippery. And in arthritis, that white pearly substance is worn away and there's just bone there, and you see bone rubbing against bone. Usually we replace the ball and the socket. If the socket doesn't look too bad, sometimes we'll just replace the ball. Next. This reverse shoulder is rather new. It was first approved in 2004, so it's a relatively new procedure. It's only used when there's a completely torn rotator cuff and the secondary arthritis that you get from it. It is not the gold standard by far, but it's a salvage procedure when a standard shoulder replacement won't work. But it is a good procedure, and we like to save this for our patients in the 70s and 80s rather than the younger patients. Next, please. Postoperatively, for all shoulder replacements, you're in a sling for 3 to 6 weeks until you have control of your shoulder on your own. You'll be doing exercises and therapy day 1. No driving for about 6 weeks, and you start light lifting at about 2 weeks. And I'll entertain all questions after Gary and
therapy. But secondly, in my wildest imagination, over the years, I always imagined someday being able, in a seminar, with my son. That's kind of a special moment for me, and I'm really glad I got a chance to do it. Dr. Busch, always enjoyed hearing Dr. Busch. We learned a lot of things. I'm going to try to focus on a couple things so you can take something with you that when you think back on tonight, you can say, well, my shoulder hurts. Oh yeah, that's right. So I'm not going to try to give you a lot, but I'm going to give you a different look at the way you probably thought of physical therapy or exercises for these kind of shoulders in the past. I brought along with me tonight Linda, where she's at, one of my past patients. I'm going to bring Linda forward. I'm going to ask her a couple of questions, and then I'm going to go take what Linda talked about and put it into something you can hold and remember. All right. Linda had a rotator cuff. Now, Linda, what did you do for work then?
Okay, I was a health and physical education teacher for 30-some years, and I played competitive volleyball for 43 years, so I used my arms a lot.
So here I have a volleyball player who has torn her rotator cuff. You know what her desire is. What did you want to do? What are your goals in physical therapy?
Play volleyball again.
So the first thing she comes at me and says, when do I play volleyball? We're in a sling. You heard him say 3 to 6 weeks on those slings. First question, when can I play volleyball? Now that could come back as you as a shock, but you know what? That comes to me as a blessing, because I now have a physical education major who wants to get back to playing volleyball, who has to learn how to exercise just the way I tell her. My odds are good because of her understanding of exercise. So you had the surgery done. Tell me about, you had some responsibility in your rehab. What did you have to do at home?
I had a home program. I would go to therapy 2 to 3 times a week where he would take care of me. And then he'd give me a program that I was supposed to sustain for the days that I wasn't in therapy with him. And it was really important that I do what I was told to do so that I could progress and get back to playing volleyball.
And how did you progress?
Oh, very well.
Did you?
Very well. I looked back, and about a week later I was back at work, and about 7 weeks later I was doing most everything, and the first time I had an impingement on my right shoulder, and then years later I had an impingement on my left shoulder, and then years later I had the rotator cuff surgery done. And I got back to playing volleyball in 8 weeks and 12 weeks. Now, rotator cuff was a little longer than that.
She talked about what she had to do. If I had to tell my students, when I get physical therapy students coming through, I tell them this is the thing you'll learn about being a physical therapist. Number one, what you do is 10% of the success they'll have. What they do is 90% of the success you'll both have. So we established some goals. We established the fact that exercise was important. And then we gave her things to do. Her success rate was good. Did you keep doing your exercises after you were out of physical therapy? I didn't want to embarrass her, but you know what? When I give exercises for home programs, my first thought is, you have to understand why I need you to do this. And that's what I'm going to talk about tonight. Thanks, Linda, so much. Yes. Okay. Going to make a little bit of a drawing here to explain what I'm trying to do so everybody can see. Can you guys see? Let's turn it a little bit. Then you guys can see? Good. This is my favorite thing to do with my patients when they come in. Some time ago when I was, I gave a lecture some time ago, and this kind of just fell into the lecture, and I've used it ever since. I'm going to make a little drawing here in a circle. It's going to represent pain. There's some causes for pain, and we're going to talk about them. Now, if I say pain is the good guy, everybody that believes and buys into that, raise your hand. You must have been in physical therapy before. Eh? Because pain is nothing more than a messenger. He's a messenger. Dr. Busch had it right on the target. You can take those injections, those steroids, you can take the medicines you want, you can use ice cold and everything you want, but you're shooting the messenger. That would be like if I took my son Jared and said, go out in this drug cartel, get me all the information, all the names of the people, and when he came back I shot Jared. Wouldn't make any sense to shoot the messenger. So why do we do these things? Why do we do these medicines injections? Because sometimes we got to control this guy so we can do the things we need to do. We need to put ice on so we can control the things we need to do. We're going to inject it so we can do the things we need to do so we can take away the cause. This is a shot at the symptom, pain. Causes we're going to talk about. Two categories, cause. We're going to talk about pathological causes and physiological causes. Big words. One means bad, one means not so bad. The pathological ones, when you see your doctor, these are the ones they do the studies for. And he showed you some bad stuff on that presentation. Those arthritic shoulders, that torn cuff. Just recently, I had a patient come back last week. He went out to get his shoulder's killing him. Can't sleep, up at night, can't work, wants to throw up when he comes to therapy. He went to get his MRI done and his x-ray because that's all he wanted. In the internet and on it says on the normal treatment I should have an MRI. So he got an MRI done. It was negative. That means they didn't find a tumor, a cyst, a tear, a fracture, a labrum. They didn't find any of the bad things. They didn't find a fracture. He was sad that they didn't find that stuff. You know why he was sad? Because he said, now no one knows why I have pain. That's not true. This side of the formula, the pathological, has some bad stuff. We saw some on that video. And because it's bad, it can have an influence on this side as well. Now we're going to talk about this side. Has anybody ever had their arm in a cast?
Come on, somebody had to. There you go. How long were you in the cast?
A couple months.
Okay, when it came out, was it stiff? And was it sore?
More stiff than sore.
Okay, so he had this stiff, sore shoulder. Here's his arm in a cast. Nice cast. There's his shoulder. Here's his elbow. Let's put this part in with nothing wrong with it. And when it comes out, nothing wrong with it. It's stiff and some soreness. That's just with loss of range of motion and strength. So when we talk about this physiological part, it has two players. Player number one, player number two, range of motion, strength. Losing range of motion and strength in a cast makes a joint sore that wasn't even bad. So consequently, when we feel pain, some of the messenger that we get comes from this side. Yes, we may have something over here that's minor or even major that requires us to be in immobilization that does lose these, but without a doubt, loss of motion, range of motion, and strength will in itself be a pain generator. And the reason for it, when we lose range of motion or strength, that word's mechanics, we change the way they use it. If my shoulder hurts, when I pinch it picking up, I start picking it up like this. I start lifting it up like this. I start doing this to go behind my back. All those substitutions are mechanical changes. Because I'm not using it the way it was designed, I can start getting problems above, below, or at. So let's say it's your shoulder. But you have this bad neck ache that just won't quit. You've got this elbow that's sore on the inside and the top because every time you try to reach in, it won't go there, and you reach in with your forearm and it gets sore. So now you're scattering your pain below, above, and at. And the reason for that is, everybody's familiar with the itises. Tendinitis, bursitis, capsulitis, arthritis, myositis, all the itises. Those itises are caused by doing it the wrong way. Having another part doing what it wasn't designed, you cannot expect it to feel normal. I tell my patients this: abnormal can never feel normal. I mean, you can't fault me for that. You've got to talk to the grand maker. If something's being used wrong, it's going to feel wrong. Something's used right, has a chance of feeling right. But abnormal can never feel normal. And the messenger to tell you you're doing it wrong is pain. So with this in mind, all right, I'm going to now jump over here. I think I'll leave that though. And bring my son up. My other son's here. This is why I had sons. All right. This is my son. For that reason, he really believes in flexibility, and he has none. I've told him, I told this one too, I told them all, you have to stay flexible. It's why I, at 64, can still do some of the things I do. So consequently, we're going to show him some of the reasons and some of the ways people cheat. All right? Now he's going to first put his arm straight out to the side. Now, it looks the same probably to you on both sides. But if you look at his shoulder, this is your sore one, isn't it? Mm-hmm. Yeah. You see how this shirt just folds in like it's supposed to? That's because this wraps around. Remember what Dr. Busch says? The ball ducks underneath there, takes that shirt down. This one looks flat because this, remember when I showed you how they cheat? That's a cheat. Right? Put it down there. Put your hands behind your head like you surrendered. In this position, what you should see is, this is for extra rotation, two triangles. These two triangles should be roughly the same on both sides. Let me look. This looks like somebody squashed this triangle, doesn't it? That's because this shoulder, taking this shirt, sticking up, because he's cheating. All right? Let it down. Hands behind your back. I'm really sorry I'm doing this. Huh? Go ahead. Hands behind your back.
Where at? Low?
Not like that, yeah. In that position, you can't see it, so I'll turn them around. If I take my hands and go across his back, I run into his wing bones. They shouldn't be sticking out like that. If I put my hands behind my back, it's flush. He can't do it because he does this to make that motion. He is in a backup system. Turn around. All right, let your hands down. All right. It's like having a limp in your shoulder. You ever see the person that sprained their ankle, then limps, and then months later still walks with her foot turned out the side? That's a habit limp. The human body's made up of all kinds of systems and backup systems. We automatically slip into those systems so that we can keep going even though it's not the right way. Thank goodness for it. We use it actually many times with people with broken necks, quadriplegics. We can get them to use their arms in a way what's left wrong, but they can get around. Will it last? No. Will not last the wrong way. So consequently, thanks. There's a right way of doing it. Now, remember all those pictures you saw. This is one of your rotator cuffs. Here's another guy. This goes underneath. And these guys around the back come in through here. He talked about the fact that it spins the ball around. Now, this bone on the top, roof bone. Touch your roof bone. Everybody knows where that's? Got it. Collarbone, squiggly guy in the front. Got it. Arm bone, ones you're moving. Wing bone, that guy in the back that his was sticking out sideways. What was happening? There's a ligament in here on Jed and on every one of us, and ligaments keep joints from falling apart. They're number one. Don't have ligaments, you dislocate. Tear a ligament, you dislocate. It holds the joint, the balls together, the two bones. The next guy are the rotator cuffs. They're the steering guys. As he talked, Dr. Busch talked, they steer the ball down underneath. Because right here, you saw him repair it, is the only tendon in the body that sits between two bones. Now you might argue with the way it was designed, but that design gives us the ability to do something that other species can't. It gives us that ability to have motion in our shoulder in a myriad of directions. This roof and this ball would pinch together and catch that guy if he can't steer it through there. Well, what could stop it from steering through? Remember we talked about range of motion loss? If this ligament gets tight, how would it get tight? Remember we said you're in a cast, things get stiff? How many times have you had your hand up above your head higher than you look? Most of the time you're out here, and if you look at that, it's a lean back, and it really isn't up in the air at all. We start losing things when we don't use it. You don't use it, you lose it. Subtly, we start giving up motion. Well, what's so important about that? When I pick my arm up, right now, take your hand, put it in your armpit, and you'll feel a ball bulge in there. Unless you've got a bad shoulder. Then it won't bulge in there. That bulge is your humerus coming in there. If it's too tight, watch what happens. If everybody's waving, that's neat. If it's too tight and the arm comes up, the ball goes here, stops, slams up, pinches the tendon. The very tendon that's supposed to be spinning and steering the ball. So one of the things we need to do is make sure we got that range of motion, and that's what we'll look at first. Then we'll look at the guys that steer. If they're getting pinched enough, Boy Scouts, you have a rope. You forgot your knife. You have to cut the rope. You take 2 round rocks, you bang them together, and soon what happens? The rope frays and tears. Degenerative rotator cuff tear. You bang it enough between 2 surfaces, expect it to wear out, flatten. You know how you tenderize chicken and it gets skinny? Imagine doing that to your tendon. Getting it skinnier and thinner, has a name actually. And then finally, you do something, it tears and say, all I did was this. Yes, but you've been smashing it who knows how long. So it's important to know this range, this guy's strong, and then, and Jared's going to talk about this, worry about the other guys on the outside.
Scott volunteered to give a little talk here. They said maybe talk about rehab for shoulder pain. I said, like you could write 10 books about that and still not be done. So I thought, in 10 minutes or whatever. So I said, what are probably the most common questions that we get? I work downstairs. What are the most common questions that we get in this office? And I thought about the questions that maybe I could help, maybe say something that would help somebody. And probably the most common question we get is, how long have you been here and why is it so hard to find this office? the first part of that is we've been here like 2 years, and I guess the second part is something to do with signs. There's no signs or something. But the next thing people usually ask me with exercise, like, why am I here? And I guess meaning the non-philosophical way of why am I in physical therapy. I said, probably because the doctor sent you. And then they say, well, what can you do for me? And I said, well, like my dad was saying, like Dr. Busch was saying, there's mechanical things that you have to change in your shoulder or it's not going to get any better. And then you could do so many different kinds of exercises and, it can get overwhelming. People say, they always come to me and say, I wanted to get my shoulder better, so I went to the gym and I started lifting weights and it hurts more. My one friend that used to go to the gym with me, he came to therapy then. He said, well, I was lifting weights, and the guy you don't want to listen to at the gym, he said, well, if it hurts when you're doing bench press, just keep putting more weight on until it doesn't hurt anymore. it's like they say that one of the definitions of insanity is doing the same thing over and over and expecting a different result. So, I started thinking stuff can get really complicated, and especially, these days, we take simple things and make them very complicated. Life has become very complicated. And I always think if stuff gets complicated, you got to simplify it. So I always try to find, models, analogies, ways to think of things. And so I kind of made, a little model that's similar to, everyone knows the food pyramid. When I explain to patients, I'll say, think of what the food pyramid is, why they have it like that. I don't know much about food, but I know they got grains somewhere and vegetables and not. And whatever's on the bottom, you want to do the most. Whatever on the top, you do. That's the least. So what I try to do when I'm talking to people and I'm saying, well, you could do this exercise or that exercise, and they're like, well, I can't come to therapy, or I'm going to have surgery. What am I going to do after surgery? I say, well, let's simplify it. Let's just make a model for you to use. So I usually just, sometimes I draw it, sometimes I just tell people, but for this we'll do like that. So, and like my dad was saying, there's different things that you need to work on, when you lose this mechanics in your shoulder. You need to start somewhere. So I was use like a baseball player. Everybody knows what a baseball player looks like when he's throwing a ball. So the first thing, if you want to throw a baseball, or if you want to, hit a golf ball, or if you want to work in your yard, or some people it's just as simple as walking up and down the steps. The first thing you're going to need is range of motion. So I put this on the bottom. If you don't have range of motion, if you can't move your arms, you're not going to be able to do anything. If you can't move your arm in the right position, you're not going to be able to throw a ball. So you have to get your range of motion. Like my dad said, if you don't get the range of motion correctly, you'll end up compensating, you'll hurt other joints, you can end up tearing your rotator cuff off, you can pull muscles. All those things can happen because of range of motion. There's all different kinds of range of motion. There's just lifting your arm up and down, there's having someone else move your arm around, there's stretching, and that's the kind of stuff that you would need, a therapist or a doctor to kind of show you what specific range of motion exercises that you need. So, but after you get your range of motion, a baseball player, he can move his arm in all the positions. After that, what you want to work on is going to be, your strength. If you get your motion first, then you start working on the strength. I have part of our family and friends and stuff are personal trainers, so they used to call me on the phone and say, what should I do for this guy? What should I do for this guy? I said, if I was a personal trainer and someone came to me, the first 2 or 3 weeks, all we would do is stretch. We'd make sure they had all the motion of all their joints. Then after that, we'd start doing some strengthening exercises especially for the muscles that a lot of people don't work. We all know the muscles here, but there's hundreds of muscles in your bodies that many people don't use. You know, hundreds of years ago, the Indians, everyone, they were climbing trees, running across the plains. They're using all their muscles all the time. We don't use them like that anymore. So we lose range of motion, we lose strength. Once you get these two things back, then you want to work on what I would call like your form, your technique, your posture, your core exercises. If you watch a baseball player, if I stretched your arm out and then we did some strengthening exercise and I said, okay, now you can go pitch for the Phillies, it's not going to happen. You have to get someone that's going to show you how to throw the ball correctly. You have to have someone showing you how to lift correctly. You have to have someone show you how to hit a tennis ball. Anyone who plays golf knows that just because you stretch and strengthen doesn't mean you can hit the ball, you know, 300 yards down the middle. You need someone to teach you how to do it the right way. Then after you have all three of these things, then what you're going to do is your exercise. So a lot of people will say to me, you know, I wanted to get in shape, so I started playing racquetball. I said, well, did you stretch for a couple weeks first? No. Did you do any strengthening exercise for your rotator cuff? No. Did you take any lessons or have someone show you how to hit the ball correctly? No. Well, you skipped these 3 steps, went to the top step, and you got hurt. So I think a lot of people get hurt that way. It could be as simple as jogging, hiking, like I said, stairs, golf, anything like that. If you're going to do anything kind of exercise, you want to start from the beginning and work all the way to the end. And that's the same way we do it with surgery. After someone comes in with a shoulder replacement or a rotator cuff repair after we have surgery, we'll start just with range of motion. If someone gets all their range of motion back in the right time period, then we start doing a little bit of strengthening. Then after we do the strengthening, like my dad was saying, we watch how they're lifting their arm. We make sure you're not compensating. We make sure if you're going back to baseball, we have kids who play, you know, baseball, hockey, soccer. Are you throwing the ball the right way? Are you hitting the ball the right way? And then after you do all those things, then you can go back to your sport. And then, you know, like my dad said, you got to keep with it. You got to keep doing your exercise. You got to stick with it, and then, you know, progress it down the road. The other thing that people usually ask me is say, okay, I got all these exercises. So how do I know if it hurts? If it hurts when I'm doing it, should I stop? Should I do something else? I kind of made up a general rule. This is something you got to talk to your doctor. You got to talk with your doctor about. You got to go by your own understanding of how your pain is. But my general thing is this is what I do. When I'm exercising, if I'm in the gym and I'm bench pressing and I have some pain in my shoulder, what I'll do is I'll say, if it hurts while I'm doing it, maybe I'm going to stop. And I'm going to check that my technique is correct. If my technique is correct and it hurts while I'm doing it, I'm going to have to stop that exercise and back down here. Maybe start with my range of motion and go back to my strength, make sure my form is right, and then try it again. So when you have pain during an exercise, you reevaluate it. Am I doing this correctly? And if you are and it still hurts, you have to stop and move down on the scale. The next way I do it is if it hurts immediately after. So say, you know, you're out in the garden and you're doing stuff in the garden, you get back in and all of a sudden you got pain in your shoulder. And then you say, okay, what I'll usually tell people is that you probably did a little too much that you weren't ready for. Back off the intensity. So, if, you know, despite what my friends, the advice he got at the gym, usually if you're lifting too much and it's hurting your shoulder, you want to back it down a little bit. If you back off the intensity, if you back off the weights you're doing, you know, and it doesn't hurt, you probably can slowly work back up to what you were doing. And then if I always tell people if you have pain, you know, a day or two after, it's pretty normal. You know, most people, especially when they're starting to do something new, they get a little sore in the muscles. And, you know, once you do it for a while, that won't be a problem anymore. The other thing I would say is if you get pain afterwards and it's an intense pain and it persists long enough, you know, you definitely want to talk to a doctor about that. So.
Thanks. And one final thing is then we'll take some questions. I thought of it while I was talking, and I didn't know how to get into it because I didn't want to move into this in case I would cover everything, and that's my problem. Total shoulder replacements. Just like total knees, just like total hips, just like total ankles, total anything. You're putting something new inside, but if you haven't prepared it, you still have an old, bad structure on the outside. So if you're thinking about, or you're at that point, you're talking to your doctor, take some time, find some time, get what you can before your surgery. Like the athlete, he has it all. Get as much as you can, because afterwards, if you put a new shoulder, new joint, in a bad tight shoulder, working with us is not as much fun as it could be. If we have every little bit makes a difference on what we can do. So if you're thinking about those things, and you're at that level of your life and you're wondering, talk to your doctor, see if you can't get some beginning rehab, because you may find, and I just had a lady who's doing so well with her knee that she's going to wait on her knee replacement. The doc said that's great, because the better she gets, when she does finally need one, the easier will be her rehab. All right, thanks everybody. Dr. Busch, want to come and get some questions? Ask him all the questions, that's fine. Any questions? Yes.
Dr. Busch, in some of those examples, illustrations on the screen, it showed the rotator cuff, but it seemed to me there was a sheath that went around. Is that also part of the rotator cuff?
I believe you're talking about kind of a red thing coming down.
Well, I didn't see a red thing. It was white. It was a thin strip coming around it, and I'm curious, the word sheath, that's the reason why I'm using it, is because, and this is a personal thing, apparently this sheath has degenerated. I don't have anything between the bones. So what do you do there to repair that? Does that require partial shoulder replacement or total shoulder replacement?
It would depend how big. What you're talking about as a sheath, I think, is the rotator cuff itself.
Well, the doctor did not mention rotator cuff. I don't know the other word for it. But
Bursa.
Well, could have been. Could have been bursa, but it's just bone on bone. That's simply that's it.
If it depends how big the tear is. If it is a torn rotator cuff, if it's arthritis, when you're talking about bone on bone.
I think it's more arthritic. There was no tear.
Well, if the rotator cuff is intact, you're bone on bone, then you could have a conventional shoulder replacement.
Now, the next part of this question
just the ball or the ball in the socket.
When you have that done, I've also heard that I'm an active person. I ski and I play golf and do things like that, that I may not be able to lift more than 25 pounds. I may have a little problem being active in skiing, playing golf, that sort of thing, when I have a total replacement.
I think we try and limit. I would be a little bit uncomfortable with you skiing, not for the act of skiing, but for the falling. You know, damaging it that way.
I'm fortunate.
Golf is fine. You know, you should get your range of motion back. That shouldn't be too difficult. You know, in the upper extremity, you're not seeing the forces generated across the joint that you do in the lower extremities, like with a hip or a knee. So I think golf would be.
Golf is good. I have tennis. I usually ask them to play doubles, so there's a little less hitting, a little less reaching. Real high above the head service.
Serving is
a little difficult, but there are ways to serve, side serve. By this time, when they come to me, they're already have gone down to that side serve off the top. If you're playing for the recreation of it, it'll be great. If you're still trying to make the Wimbledon, you're going to be sad.
Thank you.
Yes.
A question for you, sir. It seems that in the diagnostic mode, a lot of emphasis is put on the MRI as saying what's wrong. Question really is in three parts. Is there any other diagnostic tool that you would use if you didn't have an MRI available? Two, how successful is the MRI in predicting, in looking at it, how often is it right in saying you've got a rotator cuff problem or not? And 3, if you have an MRI that says everything looks fine, but you've still got chronic and acute pain, what do you do next?
Well, first of all, most orthopedists make the diagnosis on the basis of a history and a physical exam. Talk to you, see what your pain is, how it started, how long you've had it, where it hurts you. Do an exam to see what your strength is, your range of motion. And then we're doing an MRI to confirm what we suspect. This is what we do all day. So for us, the MRI is mainly a confirmation. I may not be able to tell whether you have a partial tear that's 90% or a complete tear, but I can pretty well tell you you have a tear, and I just need that MRI to tell me how bad it is.
And if the MRI says no, you don't have a tear, but you still have the pain?
You may not have a tear, you may have an impingement.
Okay, which is really what? What's an impingement?
Tendonitis, bursitis in that shoulder.
Okay.
And then, you know, it's...
What do you do to fix that?
Remember when we talked about when your arm comes up the top, if it doesn't make it, you pinch on the tendon, and you pinch on the tendon. I said, finally, if you have a rope with 2 rocks, well, that's what an impingement is. You're squeezing that tendon. Sometimes you got a spur there, and the doc will take that spur off, but they still have pain because now they're banging that bone up against the denuded area because the thing that had happened, they lost motion, hadn't been rectified yet, and until we get that ball in that armpit and ducking away from that roof so it doesn't pinch in the top, then it can go away. The surgery doesn't necessarily correct the mechanical impingement, just the pathological disparity. So we just need to get you more mechanical.
If you try, like I was saying right here, if you're missing any of these things, you can get pain. If you don't have range of motion and you try to use your shoulder, it'll hurt whether you have the rotator cuff tear or not. If you don't have the strength and you're trying to lift something you don't have the strength for, you can hurt your shoulder like that. If you're not doing, if you're throwing a baseball the wrong way, if you're lifting your arm the wrong way, if you're reaching behind your back the wrong way, any of those can give you pain. Whether there's a rotator cuff tear, sometimes there is, sometimes there isn't. Sometimes there's a labral tear, sometimes there isn't. But if I
can just persist, though, I'm sorry, at the expense of other people who I'm sure have got a question. If the MRI says that you haven't got a rotator cuff, can you have a problem? Can you really be rest assured that you really don't have a rotator cuff, that it's almost certainly something else?
I would say you probably don't have a rotator cuff tear. You may have neck problem giving you shoulder pain. You know, a cervical disc can give you shoulder pain. But again, that's the kind of thing that I'm looking at when I do my exam. And when I talk to you, I know that. And, you know, I can't emphasize how important these guys are. I would say 90% of the patients that I see, and I examine them, they're coming to me for shoulder pain, and it is real shoulder pain, have loss of motion, and they don't know it until you point it out to them. And I say, you know, I've been dealing with this for a year, and I never realized that I can't move my arm. But I think if you have a normal MRI, you probably don't have a rotator cuff pathology.
Would you say that again, 90%
of the patients that I see with shoulder pain that have had it for a little bit of time have lost motion and don't realize it until I point it out to them. You know, I measure one arm behind their back against the other, rotation of one arm against the other. I lay them flat on the table. The pitchers are the worst. You know, the throwers, the tennis players that come in with the shoulder pain, and like Gary said, they've lost. The first thing that you lose is internal rotation. And then you're throwing, you're pitching, you've got to come forward like this, and your arm stops. It doesn't go any further. And that just jams everything up inside, and the mechanics are off. And I send them to physical therapy, say, this is all you need is physical therapy, and they come back, and they say, you know, I thought you were crazy sending me to physical therapy. You're just blowing me off. But that stuff really works. If you restore the mechanics, the pain is going to go away.
That same question, remember the man that last week said they didn't find anything, and I'm sad because my shoulder hurts and they didn't find anything? That's good. You don't want to find anything. They're looking for bad stuff, bad stuff. If you don't need to get that stuff, that's in your favor.
Yes.
You're a surgeon, correct?
Yes.
Do you ever get surprised once you make the hole and look in there?
Not really. I mean, I may see something else, but between the exam and the MRI,
You're pretty well sure what you're doing before that hole gets made.
yeah.
My tear didn't show up on MRI either, and they did an arthrogram, and that's when he saw, he knew I had a tear, but he didn't realize it was a full thickness, which
Well,
it
that's-
was. So that
That's true.
was something different.
But he was smart enough to say, you know, this looks, acts, and smells
Right,
like a cuff tear. I just
Right.
can't prove it. You do the next test.
right.
You know, for those who don't know, an arthrogram is where they inject dye into your shoulder. So it's a needle. I don't know whether he did an MR arthrogram where they inject a special dye and then do the MRI, or just a regular arthrogram. But that would be the next step if, you know, like I said, if it looks, acts, and smells like it, you don't see it.
Yeah,
That's
and
what you do.
that's why he did that.
Yeah.
Do you suggest physical therapy prior to surgery? And would that make the condition worse?
I can answer that one. No.
No to what?
No, it won't make it worse.
Okay.
Remember the range of motion? He said there are different ways of having range of motion. If I pick my arm up with that supraspinatus tendon pulling to lift my arm up, you know how you hold a baseball bat on the end and it's hard to hold it? Well, this little tendon's way up here has to help turn that big arm underneath there. We wouldn't do weight training with that, but because we know it's got a tear in it, we'll now do all the passive range of motion so that we have all passively, it's folding back on itself, folding on itself, can't injure it. It's the same thing we'll do the day after surgery. We won't have you try to pick up and ruin the repair. We'll pick it up passively, fold it back on itself, keeping the range, getting the 6 weeks, getting the healing, and then eventually start letting it get strong. So there's things we wouldn't do with the MRI. We actually know exactly what not to do because we know exactly what's torn and what's not.
So I guess the thing is that after surgery then, would you have a better chance of recovering faster if you had...
Just like the athlete, we can get that motion. And back in the old days when insurances were a little more compatible to what we wanted to do, that's what we did all the time.
Okay.
Now it kind of depends on, and the doctors will do it. You try it, you don't try. We'll send you to physical therapy. If you do well, bless you. We didn't find anything MRI. We found something, let's get you ready. If you saw an ACL, and you heard of the ACL, you've heard of ACL tear in athletes. When I get them, when they feel like they don't need surgery, then we get surgery, because then they're ready.
And let me just expand on that a little bit. When I talk to my patients, I tell them, day 0 of your rehab isn't the day of surgery. Day 0, 6 months earlier, when you stopped using your shoulder because it hurt you too much, and those muscles atrophied, and the capsular ligaments contracted, and you lost your range of motion. I would love to send everyone to physical therapy pre-op. Unfortunately, the practical issue is most insurances won't pay for it. Or you may have a cap on the number of therapies you're allowed. You're only allowed 30 per year or 30 in a lifetime. And I've actually said to a couple of patients that have used up all the physical therapy, either you're going to pay for therapy yourself, or I'm not going to do your surgery because you're not going to get better.
So check with your insurance first, see what they
Well,
think.
we do that as part of, but day 0 of your rehab is not the surgery. It's when your symptoms first started and you stopped using it.
What if you can't get an MRI?
There's problems, and you have to have some discussions as to what you're going to do and what your expectations are. And
I had a gentleman because of a health issue and couldn't have one done, and it was so obvious there was something there. The doctor did a diagnostic arthroscope. Means he looked in, he signed, if there's a tear, I'm going to fix it. Looked in, found a tear, fixed it, came out.
You asked me for insurance issues, or
No,
because you pacemaker? We can do an arthrogram where we inject the dye. I thought you were asking if the insurance doesn't pay for it.
Yes.
Fairly active, lift weights, no problem, bench press, overhead press, lateral raises, a lot of gardening, a lot of digging, a lot of hoeing. Every now and then I get ache in the shoulders. Not a pain, but aching. What could that be?
Well, we're going to have a little bit of a screen thing down the back. If you find me down there, I'll tell you what I think.
Right.
Yes. Ewan.
Good. Is it possible to restore range of movement, strength, for a full tear in your rotator cuff with just physical therapy? That's how I approached it, and I'm 4 weeks into it, and it's doing pretty well.
You can do pretty well.
Okay.
You may not get all your strength back, but certainly a functional.
Okay.
It depends how big your tear is.
Okay. Well, full thickness tear and partial tear in the biceps tendon and shredded labrum. And actually, the pain's really just coming from the biceps tendon.
Yeah.
So.
You know why that is?
Okay. What's that?
You know why that is?
Yeah.
Because your bicep tendon is making believe it's a supraspinatus tendon. It really is. It's it's trying to be a depressor of your shoulder. Remember, he said it has to hold it down while the arm comes out. Well, it ends up getting. Remember, we said it'll do it, you'll overuse it, but it'll finally fail. And that's what happened.
I always think we get a bunch of guys from Northwestern, like farmers and stuff, and a lot of those guys have had rotator cuff tears for like 20 years. You know, every once in a while they'll come in and be like, I got a rotator cuff 20 years ago. Check my arms out, I'm pushing, I can't, they're stronger than me. And they're like, I get some pain once in a while, just give me a couple exercises, I'll do them at home. Full thickness tears on both shoulders, they're still working on the front.
Well, that's good to know.
Yeah.
So building up those other muscles.
There's a couple motions, especially what we call external rotation, where you're pushing your arm out this way. That your rotator cuff mostly does that motion. But all the other motions, if you do it long enough and you keep the pain level down and you make sure you keep your range of motion, your other muscles will usually make up for most of those stretches. Eventually.
I like that answer.
Actually, kind of in conjunction with that. So if you have a partial tear and you do maybe a mild exercise, like you're a walker or a swimmer, a mild swimmer. I mean, I had this I'm visualizing on a piece of paper that if partially torn, it's going to tear more easily. And like anything like reaching, it's going to make it tear faster. Is that true, or is that? I mean, are you more like absent an acute injury, falling or something? You just go about your daily business and do sort of mild type of activity.
Well, the swimming can be hard on your shoulder because it's overhead.
Yeah.
So you're pinching again, like Gary said. That's anything overhead is going to aggravate you, and if you're continually doing it.
When you say aggravate, you're more likely to tear or
Well,
hurt more.
Yeah, if I can add to that,
Yeah.
something happened to cause your partial tear. Swimming doesn't cause partial tears. If it did, then everybody that swam would have partial tears. And I got guys that are in their 90s and are swimming yet. So something's different on you. Something range of motion wise isn't right. And you're swimming as much as you think correctly. Remember Jared talked about the form? You're doing something wrong. If you continue swimming wrong long enough, you will continue to shred that tendon. If you get it taken care of and then make it right, you can probably swim like the 90-year-old. You need to make a change in something because it's already given you, the pain is a messenger. He's giving you a message, you're doing it wrong. Or swimming wouldn't do that to you.
Once it starts to tear off the bone, though, does it make it more receptive, tearing more?
I have a 50% tear from a bicycle wreck out in Utah. My sons did this to me. Went over the handlebars, that forward roll kind of thing. When I got it done on the MRI, I got a 50% tear. If you come up here and lift my shoulder, it makes the worst sound you ever heard. Do it hurt? No. Do I do all my work? Yes. Am I strong as a bull? Yes. I don't have a problem with it. Because I have all my range of motion, all my strength, that 50% is suffice. You need to know that you've got to make some changes, and then you can probably continue what you want to do.
Yes. In a complex or compounded situation, when you know you have a cervical spine, a herniation or bulge or something, and it's firing up the shoulder and all, would you ever treat both at the same time, or once you find out what's, like, say, the prior issue or the secondary issue, could you, or would you treat both at the same time?
Well, you wouldn't treat surgically both at the same time, but you would certainly treat physical therapy injections at the same time.
Remember when I said the drawing here? If this, remember when my son was picking his shoulder up like an airplane? That's because of these muscles going up here. If I pick my arm up and I'm pinching this, the way to get that out of there is to move the roof out of the way. That's why they end up making this substitution. You see people lifting all the time. They're using this muscle. That puts all kind of stress on the cervical spine. There isn't any time that you come into place, if you got a shoulder problem, I wouldn't trust your neck. And if you come in here with a neck problem, I wouldn't look at your shoulder. Because it's a joint above and below, they have stress forces relationship, and so I would do them both, even if you didn't have a history of it.
Yes.
Can your sleeping position cause a problem of range of motion that would give you some pain in your shoulder?
I don't think it would give you a problem with range of motion, but the people that sleep with their arms over their head are impinging.
So they're causing the impingement.
Yes. And they're sleeping in the impinged position. It's not good to be in the end of any range. All right. But as far as taking a different look at your question, when people have surgery, they ask me, what position can I sleep in? I don't want to lose any of my motion. Get sleep. Whatever position is comfortable is probably the correct position. It won't injure anything. Initially, you're going to wear a sling if you have one on. Later, when you come out of it, you're going to wish you had the sling because you're going to feel naked without it. But without that sling, get any position that's comfortable. And you say, we don't try to change range of motion in your sleep position. If your arm hurts when you're laying in a position at nighttime, it isn't from the position. It's from the fact you don't have enough range of motion to sleep in that position. Therefore, you're pinching yourself.
So it's still, I mean, the sleeping is just showing you
that you got something else
that,
wrong.
that you've got something that's not.
That's that messenger. That pain's a messenger saying you got something, you lost the motion.